Welcome to this video on blood transfusion in surgery. Blood transfusion is a critical, life-saving intervention in various surgical settings. This video will cover the definition, historical origins, relevant hematology, indications, contraindications, and principles of blood transfusion, as well as complications and specialized techniques. Blood transfusion is the transfer of whole blood, or its components, from a donor to a recipient, or within the same individual, which is called autologous transfusion. It is vital in trauma, hemorrhagic shock, major elective surgery, and surgical emergencies. The foundation for transfusion was laid in 1628 with William Harvey's discovery of circulation. In 1665, the first successful dog-to-dog transfusion occurred, followed by unsuccessful animal-to-human attempts. James Blundell performed the first successful human-to-human transfusion in 1818. The field advanced significantly with Carl Landsteiner's discovery of the ABO system in 1901 and the rhesus system in 1939, which provided the molecular basis for compatibility. Anticoagulants, discovered around 1914, enabled blood storage and the creation of blood banks. This image depicts a historical blood transfusion procedure from 1882. Relevant hematology includes the functions of blood and major blood group systems. The ABO and rhesus systems are the most important. ORH negative is the universal donor, and ABRH positive is the universal recipient. This visual illustrates the composition of the ABO blood group system, showing the antigens and antibodies present in each group. Blood transfusion may be indicated preoperatively, intraoperatively, or postoperatively. The general purpose is to restore oxygen carrying capacity, replace blood loss, and correct coagulopathy or thrombocytopenia. Preoperative indications include symptomatic anemia, typically with hemoglobin below 7 to 8 grams per deciliter, and known coagulopathy or thrombocytopenia below specific levels before major surgery. Intraoperative indications include acute blood loss, hemodynamic instability, estimated blood loss exceeding 15 to 30% of blood volume, and massive hemorrhage situations like major trauma. Postoperative indications involve symptomatic anemia, ongoing bleeding, hemodynamic instability, or coagulopathy requiring correction after surgery. Absolute contraindications include incompatible blood and patient refusal based on autonomy or religious beliefs. Blood salvage methods are contraindicated in cases of malignancy or active infection. Relative contraindications, where risks must be weighed against benefits, include congestive cardiac failure and a history of previous severe blood transfusion reactions. Blood transfusion may involve whole blood or specific blood components. Modern practice favors component therapy for targeted treatment, reduced complications, and better use of donated blood. Whole blood contains red blood cells, plasma, platelets, and clotting factors. It is indicated primarily for acute massive blood loss, or when components are unavailable. Packed red blood cells, or PRBCs, are concentrated red cells used for symptomatic anemia and acute blood loss. 1 unit of PRBCs typically raises hemoglobin by about 1 gram per deciliter. Platelet concentrates are used to prevent or treat bleeding caused by low platelet counts. Indications include counts below 10,000 for prophylaxis or below 50,000 before major surgery. Fresh frozen plasma, or FFP, contains all clotting factors. It is indicated for coagulopathy with bleeding, liver disease, or during massive transfusion protocols. Cryoprecipitate contains fibrinogen, factor VIII, and von Willebrand factor. It is used to treat hypofibrinogenemia, disseminated intravascular coagulation, and massive hemorrhage. Component therapy offers advantages like targeted replacement and lower risk of volume overload. However, low-resource settings often face challenges due to limited equipment and inconsistent supply. A key principle is that benefits must outweigh risks. Moderate anemia is not a contraindication to surgery, and routine top-up transfusions should be avoided. Strict donor screening is mandatory. Collected blood must be tested for infectious diseases such as HIV and hepatitis. Patient assessment and strict cross-matching for ABO and RH compatibility are essential for selecting the correct blood product. Safe blood transfusion involves the judicious use of compatible blood that has been screened for major transfusion-transmitted infections, including HIV, hepatitis B and C, syphilis, and malaria. The transfusion procedure begins with confirming the clinical need and obtaining informed consent. An accurate requisition form with mandatory patient data is required. Next, A large-bore venous access is secured, and a blood sample is taken for type and cross-match. The double-check rule requires 2 staff members to verify patient identity against the blood bag at the bedside. Inspect the unit for damage and verify that the blood group matches the compatibility label. Record baseline vital signs and start the infusion slowly for the first 15 minutes to detect acute reactions. Complete the transfusion within 4 hours. Document the transfusion details, including monitoring vital signs hourly. If a reaction is suspected, stop the transfusion immediately. Maintain IV access with saline and send samples for investigation. Treat symptoms and document the event. Post-transfusion care includes disposing of the equipment properly and educating the patient and caregivers about potential delayed reactions. Complications can be acute, occurring within 24 hours, or delayed. They can also be classified as immunogenic, such as acute hemolytic reactions, or non-immunogenic, like transfusion-associated circulatory overload, or TACO. Acute complications include immunogenic reactions, such as acute hemolytic reactions, and non-immunogenic issues, such as bacterial contamination, electrolyte disturbances, and air embolism. Delayed complications include delayed hemolytic reactions and non-immunogenic issues, such as iron overload and transfusion-transmitted infections like HIV and hepatitis. Massive blood transfusion is the replacement of a patient's total blood volume within 24 hours. It is indicated for severe trauma, major surgery with high blood loss, and obstetric hemorrhage. Massive transfusion involves a balanced ratio of PRBCs, FFP, and platelets, typically 1:1. Complications include hypocalcemia, hyperkalemia, acidosis, and hypothermia, requiring close monitoring and treatment. Autologous transfusion involves collecting and reinfusing a patient's own blood. This eliminates the risk of alloimmunization and infectious transmission and is used in elective surgery. Types of autologous transfusion include preoperative autologous donation, acute normovolemic hemodilution, and intraoperative or postoperative blood salvage. Autologous transfusion is indicated for elective major surgery, rare blood groups, or patient refusal of allogeneic blood. Contraindications include active infection and severe anemia. Advantages include eliminating incompatibility risks and infections. Disadvantages involve the need for preoperative planning, high cost, and the risk of contamination. In Nigeria, challenges include a severe blood shortage, with only about 500,000 units collected annually. There is a heavy reliance on unsafe sources, such as paid commercial donors. Other challenges include high seroprevalence of transfusion-transmissible infections, limited sensitive screening capabilities, lack of equipment for component therapy, and high costs of blood. Artificial blood substitutes are designed to carry oxygen or maintain blood volume without relying on human donor blood, aiming to overcome limitations like shortages and infection risks. Artificial blood includes hemoglobin-based oxygen carriers, or HBOCs, perfluorocarbon, or PFC, emulsions, and non-oxygen carrying volume expanders, such as crystalloids and colloids. HBOCs like Hemopure deliver immediate oxygen and do not require cross-matching. However, limitations include the risk of vasoconstriction, short circulation time, and potential renal toxicity. PFC emulsions are synthetic compounds compatible with all blood types and cause no immunologic reaction. They require high inspired oxygen concentration for efficacy and are rapidly cleared by the body. Volume expanders, such as crystalloids and colloids, maintain intravascular volume but do not carry oxygen. They are adjuncts in treating massive transfusion or shock, but offer only short-term volume replacement.